Hello students, let us now come to the anatomy of inner ear. Now, the inner ear, we studied a little bit about the inner ear in the embryology of the ear. Okay, so there we discussed that the inner ear consists of two parts. Which two parts? The bony labyrinth and the membranous labyrinth. So we talked that the bony labyrinth is the bony part that forms from the otic capsule. The membranous labyrinth is the sensory part that forms from the otic vesicle. Right? Now, the space between this bony labyrinth and the membranous labyrinth, that is filled with a fluid which is known as perilymph. Okay, and the space inside the membranous labyrinth, that is filled with another fluid known as endolymph. Okay, so now let's look at this inner ear. So this is the inner ear. Over here you can see the yellow color, that is the bony labyrinth, and you can see the blue color, that is the membranous labyrinth. Right? Okay, now see, between the bony labyrinth and the membranous labyrinth, the space is filled with perilymph. So it is known as perilymphatic space. Now inside the membranous labyrinth you can see that space is filled with endolymph. So it is known as endolymphatic space. Alright, so we have perilymphatic space, we have endolymphatic space. Alright, so that was one way to study the inner ear. The other way to study the inner ear is by its function. Okay, so that means we can divide the inner ear once again into two parts. The anterior part, that is the auditory part, and the posterior part, that is the vestibular part. Okay, auditory part, the part for hearing, that is their cochlea. Alright, so this cochlea, you see, it has two complete turns and 3/4 of the third turn, that means 2.7 turns around a central axis known as modulus. Let's look at this cochlea. So we have this cochlea, it has 2.75 turns around the central axis, which is known as modulus. Right? Okay, so that was the anterior part. Now, the posterior part, you see the vestibular part can be divided into two further parts. The vestibule, that is the central part of the inner ear, and then we have the three semicircular canals. Okay, so you look over here, this part is the vestibule, and then we have inside the vestibule two sac-like structures. So the membranous labyrinth, you see, inside the vestibule has two sac-like structures, the saccule and the utricle, and then we have three semicircular canals. Right? Okay, so that is the anatomy of the inner ear. You can see the vestibule has two parts, the saccule and the utricle, and there are three semicircular canals, superior, posterior and lateral. Alright, okay, so now what we will do is, we'll study the inner ear into two different parts, the vestibular part, the part that is associated with balance, and the auditory part, that is the part associated with hearing. Okay, so let's first start with the vestibular labyrinth. That means the part of the inner ear which is associated with balance. Okay, so vestibular labyrinth. So vestibular labyrinth, we know, consists of the vestibule and the semicircular canal. Okay, the vestibule has two sac-like structures, saccule and utricle. The semicircular canal, there are three semicircular canals. Let's do one thing. Let's remove all this bone. So when we remove all this bone, we can see only the membranous labyrinth. Okay, so you can see over here, I have removed the bone. We are able to see only the membranous labyrinth. You can see two sac-like structures, utricle and saccule. These are in the vestibule, and then we can see over here three semicircular canals. Which three? Superior, posterior and lateral. Okay, so there are three semicircular canals. Now each semicircular canal, you see over here, each semicircular canal has a ampulla. One of the end is thickened. Okay, so one of the end is thickened, it has a ampulla. So that means this is the ampullated end. The other end is non-ampullated. Okay, so one end is ampullated, other is non-ampullated. So three semicircular canals, how many opening in total? Total opening is 5, not 6. Each canal has two ends, but total opening is 5, not 6. Why? Because the non-ampullated end of posterior and superior, you see, this non-ampullated end over here, it combines to form crus commune. So superior and posterior non-ampullated end combines to form crus commune. All right. So with these 5 openings, these 3 semicircular canal, they open into the vestibule. Okay. Now what is there inside the ampulla? What's there inside this ampulla? Inside the ampulla, we have hairs. Okay. Now these hairs are known as cristae ampullaris. Let's look at this diagram. We can see the 3 semicircular canals, and the semicircular canals inside them, you can see over here this ampulla. Okay, right? So that's the ampulla, and this ampulla, inside the ampulla, we have these hair-like structures. Okay, so we can see these hair-like structures. These hair-like structures are known as cristae ampullaris. Okay, now these cristae ampullaris, they are in a gelatinous material, and together they are known as cupula ampullaris. Okay, so each individual hair-like structures, these are known as cristae ampullaris. Together they are in the gelatinous material, which is now known as cupula ampullaris. Okay, so this is inside the ampulla. Remember, this ampulla is filled with endolymph. Okay, so that's a part of membranous labyrinth. Of course, it is filled with endolymph. You can see the vestibular nerve fibers coming out of these cristae ampullaris. Now, what is the function of these cristae ampullaris? Let's look at these cristae ampullaris. You can see the cupula. Okay, so that's the gelatinous material, and you can see the cilia or the cristae ampullaris. Okay, you can see these cells, these cilia are attached to the nerve fibers. Okay, so the vestibular nerve fibers, they are coming out of this cristae ampullaris or cupula ampullaris. Okay, so now what happens? You see, when you rotate your head, the fluid, the endolymph inside the semicircular canals move. Okay, and when the fluid inside these semicircular canals move on the rotation of the head, now what happens? This moves the cupula. Okay, it puts pressure on the cupula. So you can see over here the cupula is moved, cupula is bent. Because the cupula is bent, you can see over here that these cristae ampullaris, they have also bent. When the cristae ampullaris are bent, they generate a nerve impulse. This nerve impulse then goes to the brain, and by this motion we are able to detect the angular acceleration. Okay, so because of this movement of the cristae and the cupula ampullaris, we are able to detect the angular acceleration. Okay, so the function of the cristae or the cupula ampullaris is to detect the rotational motion, or you can say angular acceleration. Right? You see, the nature has given us 3 semicircular canals: superior, posterior, and lateral. Why 3 semicircular canals? Because we have a 3-dimensional space. Around us, we have a 3-dimensional space. All these 3 canals, they are perpendicular to each other. So you see what happens. Suppose I move my head like this. Okay, so I move my head like this. Now what happens? The lateral canal, also known as horizontal semicircular canal. Okay, so lateral canal or horizontal semicircular canal, now what happens? This canal, the fluid in it starts moving. Okay, so you see, this is known as horizontal canal, but it's actually not horizontal. Okay, we call it as horizontal canal. It's better named as lateral canal because it is not horizontal. It is actually at an angle of 30 degrees to the horizontal line. Okay, so if I move my head in this way, the lateral canal is stimulated. Now if I move my head like this, now what happens? So when I'm moving my head like this, the posterior canal is also known as vertical canal. Okay, so now what happens? This vertical canal is stimulated. And suppose I move my head like this. Okay, so when I move my head like this, the superior canal, which is also known as anterior canal, this canal gets stimulated. So we have 3 canals. All the 3 are perpendicular to each other. And with the help of these 3 canals, we can detect the angular acceleration in all the three dimensions. Right? So that's why the nature has given us three semicircular canals so that we can detect the angular acceleration in all the three dimensions. Right? Before we go ahead, let's talk about nystagmus. So what is nystagmus? Nystagmus is rapid to and fro motion of eyeballs. Important point, involuntary. Okay, so this is actually rapid involuntary. You should not be doing it yourself. This is an involuntary movement. Okay, which kind of movement? To and fro motion of the eyeballs. Right? Now, this nystagmus, you see, I talked about the three semicircular canals. Which three semicircular canals? I talked about the lateral, the superior, and the posterior semicircular canal. Now, if I stimulate the lateral canal, we have, you see over here, this is stimulated by the horizontal movement. Now, if I stimulate, when I am not moving, what will happen? When I stimulate the lateral semicircular canal, what will happen? Now, remember, there is a vestibulo-ocular reflex. Okay, there is a vestibulo-ocular reflex. Now, what is this reflex? Whatever stimulus is received by the vestibular system, it is given to the brain. But a part of this stimulus also goes to the eye. So that's a vestibulo-ocular reflex. And it will adjust your eyes. So that when you are moving your head like this and you are looking at some point, that point remains in the focus. So even when you move your head, your point remains in the focus, and that's because of the vestibulo-ocular reflex. Okay. Now, if I stimulate the labyrinth, okay, if I stimulate any of these semicircular canals without an actual motion, so let's say my head is stable and I stimulate these canals, so what will happen? Based upon the stimulus, they will start adjusting the eyeballs. Okay, because they think that the head is moving. Right? So that means if I irritate over here the lateral semicircular canal, so what will happen? I will have horizontal nystagmus. Okay, if I stimulate the posterior semicircular canal, I will have vertical nystagmus. Okay, you can just determine that by the name. Okay, lateral, also known as horizontal semicircular canal, horizontal nystagmus. Posterior, also known as vertical semicircular canal, so vertical nystagmus. Now, superior semicircular canal, we have torsional or rotational nystagmus. Remember, so the superior work when you move the head like this. So now the nystagmus is torsional nystagmus. Right? Okay, now before we go ahead, let's talk a little bit more about nystagmus. The nystagmus can be peripheral nystagmus or it can be central nystagmus. So what do I mean by peripheral? Peripheral means it is because of any problem in the peripheral sense organ. So what's our peripheral sense organ? The vestibule, okay, or the semicircular canals. So the vestibular organ, the vestibular labyrinth, or the vestibular nerve. So that is your peripheral sense organ, or it can be in the central. So what's the central part? The cerebellum. Right? So the nystagmus can be peripheral, that means it is rising from the vestibular labyrinth or the vestibular nerve, or it can be central. So C for central, C for cerebellar. Now, how can we differentiate between a peripheral nystagmus or a central nystagmus? For this, I have 5 Ds. Okay, so what are the 5 Ds to identify the peripheral nystagmus? Remember, the peripheral nystagmus has 5 Ds. Okay, so with the help of these 5 characteristic Ds, we can identify that it is a peripheral nystagmus. Number 1 D is delay. Okay, so number 1 D is delay. That means this nystagmus comes after few seconds of stimulus. Okay, so once you give stimulus, you have to wait for some time. It comes after few seconds of stimulus. It will not be seen immediately. Okay, so the number 1, there is a delay. Number 2, there is a duration. So duration means it will remain for some time, maybe 1 minute, 2 minutes, 5 minutes, and then it will disappear. So it has a fixed duration. Okay, every peripheral nystagmus, according to its characteristic, has a fixed duration. Right? Number 3 is decay. What do I mean by decay? Decay means if you do repeated stimulation. So if you try to stimulate this peripheral nystagmus, so after a few stimulations, now what will happen? It will decay away. It will not come. Okay, if you try to do it again and again, it will not come. All right. Next is decreases on gaze fixation. So suppose the patient is trying to focus at one particular point. So suppose this is the point and patient tries to focus when you are testing. Now the nystagmus will decrease in intensity. Okay. The eyeball movement will be reduced. And number 5, direction. Okay. So number 5, this nystagmus has direction. What do I mean by direction? What do I mean by direction? You see, suppose the eyeballs are moving like this. Okay, so my eyeballs, they are moving like this, like my fingers. What is this? This is a pendular nystagmus. A pendular nystagmus is a central nystagmus. Why? Because just like a pendulum, it is going in both the directions with the same speed. Right? Okay. How will be a peripheral nystagmus? A peripheral nystagmus will be like this. Okay. So what do we see? We see that in this peripheral nystagmus, okay, the eyeballs are going towards my left very fast. So there is a fast component. And then they are coming slowly. So there is a slow component. Okay. So that means this peripheral nystagmus, it has two components, fast component and slow component. Okay, it has a fast component and a slow component, and the direction of the nystagmus is given by the fast component. Okay, so if the eyeballs are going like this, that means the nystagmus is towards left, my left. Okay, if the nystagmus is going like this, that means the nystagmus is towards the right, my right. Okay, if the nystagmus is going like this, that means it is towards gravity. It is a downbeating nystagmus. Okay, a downbeating nystagmus, it is towards gravity. You can also call it as geotropic nystagmus. Right? So downbeating, or you can call it as geotropic nystagmus. Right? Okay, and it can be upbeating. So you see, the nystagmus can be like this, upbeating. So upbeating, ageotropic nystagmus. Right? So we can have upbeating or ageotropic nystagmus. Similarly, if the nystagmus is because of the superior semicircular canal, so we have a torsional nystagmus. Okay, now this torsional nystagmus is like this, you see. When I move my hand like this, so you are looking from there, you see it is a anti-clockwise. And if I move my hand like this, it's a clockwise nystagmus. So a torsional nystagmus can also be a clockwise or a anti-clockwise nystagmus. So peripheral nystagmus has direction, and direction is given by fast component. Clear? Okay, then we have discussed the 5 Ds of peripheral nystagmus: duration, delay, duration, decay, decrease on gaze fixation, and direction. We talked about direction. It has fast and slow components, and the direction is given by the fast component. Right? Okay, so that was about the 3 semicircular canals. Alright, we talked about the 3 semicircular canals, superior, lateral, and posterior. Other than the 3 canal, we have 2 sacs in the vestibule. They are also part of the vestibular system. Okay, so 2 sacs, saccule and utricle. Now, what is the function of this utricle and saccule? Now, you see, inside the utricle and the saccule, we also have a sensory epithelium that's known as macula. Okay, so you can see the utricle and the saccule. Inside them there is a macula. Now look at this macula. This macula also have these hairs which are known as cilia. Okay, and these are embedded in a gelatinous material. This gelatinous material, however, is covered by calcium carbonate crystals. Okay, now these calcium carbonate crystals, these are known as otoconia. Otto means ear, conia means crystal. So otoconia, crystal in the ear. Okay, right. Now, other than that, we can also see the vestibular nerves and the supporting cells around these cilia cells. Okay, now what happens? You see, suppose you go and sit in a train. You are sitting in a train and you close your eyes. The train is standing on the station. Now what will happen? After some time, the train starts moving. So when the train starts moving, your body starts moving in the forward direction. Okay, so body is moving, you see the whole macula is moving. Now what happens? Because of this forward direction movement, now what happens as a result? These otoconia, they glide back. Okay, so now when they glide back, now what happens? They lead to bending of these cilia. Okay, so these otoconia, you can see, they lead to bending of the cilia, and a nerve impulse is generated when the cilia are bent. All right, that goes to the brain and we detect linear acceleration. So what is the function of macula over here? The function of macula is to detect linear acceleration. Remember, the ampulla, the cristae or the cupula ampullaris helped us detect angular acceleration. The macula in the utricle and sacules helps us detect linear acceleration. All right. Okay. Now you see we have two macula. Why two macula? Utricle and sacule. Look at the arrangement of this. Okay. Look at the arrangement of the sacule, the macula of sacule, and look at the arrangement of macula of utricle. So you see the macula of utricle, it helps you detect the horizontal linear acceleration. The macula of the sacule, it helps you detect the vertical linear acceleration. Okay, how do I remember them? Very easy to remember. Utricle, you can write like this. Okay, so that helps me that it's a horizontal linear acceleration. And sacule is even easier. Remember the dollar sign. So this is the dollar sign. Okay, right, instead of S, I put a dollar sign, and that is your vertical linear acceleration. Okay, so remember utricle, macula of utricle, horizontal linear acceleration, macula of sacule, vertical linear acceleration. We have just seen the macula of the utricle and macula of the sacule. Now sometimes what can happen is that the otoconia which are present in the macula of utricle and the macula of sacule, these otoconia, they get displaced. Okay, so from the vestibule, from the utricle and sacule, these otoconia, they are displaced, and now where they will go? They go and lie in the posterior semicircular canal. Why posterior semicircular canal only? Okay, why? Because this is the most dependent canal. All right, so by gravity, this is the most dependent canal, and therefore these otoconia, they usually go into the posterior semicircular canal, although they can go into even the lateral semicircular canal also. So now what happens when they go into the posterior semicircular canal? You see, whenever the patient looks up or whenever the patient looks down, okay, whenever there is a head movement, what will happen? The fluid in the posterior semicircular canal will move. The movement of the fluid will lead to movement of these otoconia. Okay, and these otoconia will then over here, it will stimulate the cupula ampullaris or cristae ampullaris. Okay, and the stimulation will be more than the movement, and that will lead to vertigo. So patient will come and complain of vertigo. Okay, right? So this condition is known as benign paroxysmal positional vertigo, BPPV. Okay, benign paroxysmal positional vertigo. So what is the complaint of the patient? The patient comes to us with complaint of vertigo. What kind of vertigo? Now these vertigo are positional vertigo. So what do I mean by positional vertigo? The vertigo happens when there is a change in head position. Okay, so patient looks up, patient looks down. Patient tries to pick up something from the upper shelf, or the patient tries to tie shoelaces, or even try to wear trousers. Right? Sometimes patient rolls and gets up from the bed in the morning or gets down on the bed in the night. There is a change in head position. In any of these change in head position, patient will have vertigo. Okay, so this is known as positional vertigo. Now these vertigo, they come in paroxysm. Okay, they come in paroxysm. So paroxysm means sudden burst. So as soon as there is a change in position, now within a few seconds, there will be a paroxysm. There is a burst of this vertigo, and then it will go away after some time. Okay, so this condition is known as BPPV, benign paroxysmal positional vertigo. Now remember, this is the most common cause of vertigo. Okay, right? And what has caused this BPPV? It is the displacement of otoconia. Okay, the otoconia which are supposed to be in utricle and saccule, these are calcium carbonate crystals as we discussed. But now they have displaced to posterior semicircular canal. That is the most common canal because it is the most dependent canal. Okay, right. Now vertigo is, as we discussed, it is because of change in head position, especially the vertical plane. Okay, and it comes in paroxysm, sudden burst. Right? Duration, it may last from seconds to a minute. Right? So remember, BPPV, vertigo of BPPV lasts for a few seconds to usually a minute or just over a minute. All right? Now, these otoconia, they are now in a wrong place. Okay, oto means ear, conia means crystal. Now these otoconia are, however, in a wrong place, which are supposed to be utricle saccule. They are now in posterior semicircular canal. So we call them as otolith. Okay, so the otoconia are now called as otolith. Lith means stone. So crystals are also stone, but crystal is a respectful name for the stone. So now we don't give that respect to them. They are causing problem for us. So now they are known as otolith. And this condition is therefore also known as otolithiasis. Okay, this condition is also known as otolithiasis. Now, this otolithiasis may be of further two types. Which two types? Sometimes these otoconia, they are free. They are free in the semicircular canal. Okay, that is known as canalolithiasis. All right, but sometimes these otoconia may even become adherent to the cupula. So if they become adherent to the cupula, that is known as cupulolithiasis. Right? So this will be a more severe type of vertigo because stimulation will be more. So that is cupulolithiasis when they get adherent to the cupula ampullaris. Okay, so let's say we have a patient presents to us, gives a typical history of positional vertigo that comes in paroxysms and lasts for a few seconds, let's say 40 to 50 seconds. So we have a provisional diagnosis of BPPV. Okay, how will we confirm our diagnosis? What test we will do to confirm the diagnosis of BPPV? All right, so to confirm the diagnosis, we do a maneuver that's known as Dix-Hallpike maneuver. Okay, so this maneuver is done to confirm the diagnosis of BPPV. Now, what is done in this maneuver? In this maneuver, you make a patient sit on an examination table. As you can see over here, the patient is made to sit on an examination table. Now, this patient's head, you see, you hold the head of the patient, okay, and now you turn the head by 45 degrees towards the side you have to test. Okay, so you turn the head 45 degrees towards the side. So let's say you have to test for right side, so you turn the head to right side by 45 degrees. Right, and now what you do is you make the patient go supine. Right, now when you make the patient go supine, what have you done? You have moved the patient, especially the posterior semicircular canal of right side, in the vertical plane. Okay, so once we have moved the posterior semicircular canal in the vertical plane, that means we have given a stimulus to it. So what will happen? That will lead to movement of fluid. The endolimb inside, if there are otoconia in it, if there is otolith in it, it will move. The movement of otolith will give a stimulus. And what you have to see? You have to see in this patient nystagmus. Patient may complain of vertigo, you have to notice the nystagmus. Okay, now this nystagmus is a peripheral nystagmus. Remember, it's a peripheral nystagmus. So this nystagmus will have a delay. It will come after some time. Okay, it will have a duration. As I told you, this nystagmus lasts for seconds to minutes. 1 minute, 2 minute maximum. Okay, now this will have a decay. That means if you do this maneuver repeatedly, it will stop coming. All right. If the patient tries to fix on some particular point, it will decrease in intensity. So you will ask the patient not to focus on anything. Anyways, once you are moving the head of the patient will not be able to focus on anything, but still you will ask the patient to not focus on anything, otherwise the patient nystagmus will decrease in intensity. Number 5, this nystagmus will have a direction. Now what is the direction of this nystagmus? This is going to be a upbeating nystagmus. Okay, upbeating nystagmus we also call as agiotropic nystagmus. Now remember the posterior semicircular canal. This canal forms a crus commune with the non-ampullated end of superior semicircular canal. So that means if the posterior semicircular canal is affected, okay, there will be some effect on the superior semicircular canal also. Okay, that means there will be a torsional component to this nystagmus. Okay, so this nystagmus will also have a torsional component. In fact, remember this line that whenever posterior semicircular canal is affected, that means automatically so superior is also little bit affected. So a vertical nystagmus of peripheral origin will always have a torsional component. Okay, that also means that a pure vertical nystagmus, now a pure vertical nystagmus therefore will be seen only in central lesions. Central means cerebellar, as I told you. That's a central nystagmus. Okay, a peripheral vertical nystagmus will always have a torsional component. Okay, so similarly, the nystagmus of the BPPV in Dix-Hallpike is upbeating or agiotropic nystagmus with a torsional component. Right? Okay, now we have done Dix-Hallpike and you have diagnosed the problem. Now how will you treat this patient? Okay, you see the treatment, what is the problem? The problem over here is the otoconia or the otolith. These are in the posterior semicircular canal. Okay, you have to take them out of the posterior semicircular canal. Now how can you take them out? You see, this over here is the ampulla. So we have to rotate these otoconia all the way through this posterior semicircular canal into the crus commune and finally into the utricle ensaccule. Okay, so this pathway, moving them across this is done by a series of head movement that's known as Epley's maneuver. Okay, so this is known as Epley's maneuver. It's a series of head movement to reposit the otoconia back into utricle ensaccule. All right, let's study this Epley's maneuver. What do we do in Epley's maneuver? Now, in Epley's maneuver, we make the patient sit. So just like the Dix-Hallpike, you make the patient sit. And you turn the head 45 degrees to the side you are going to treat. So just like Dix-Hallpike, remember the first step of Epley's is actually Dix-Hallpike. Okay, so that means first step of Epley's and Dix-Hallpike are exactly same. That also means that suppose a patient comes to you with a particular history, you have a provisional diagnosis and you do Dix-Hallpike. the nystagmus is there. So that means you have made the diagnosis of posterior canal BPPV. So you have not just done the diagnostic test, you have in fact also started the treatment. Okay, so you have already done the step 1 of Eplase. So we will not bring the patient back. If this nystagmus is there in Dix-Hallpike, you will continue ahead with the Eplase. Alright, so Eplase step 1 same as Dix-Hallpike. So now suppose I am going to treat the right side of the patient. I will turn the head 45 degrees to the right side, just like we did in Dix-Hallpike. Okay, and now I will turn the patient supine. Right, so this step was same as Dix-Hallpike. Patient now has nystagmus. Alright, now at this point, the patient, you see, the patient eyes are looking at the right upper corner of the room. Okay, you can see patient is looking at right upper corner of room. Now what you will do is you will rotate the patient's head by 90 degrees. So when you rotate the patient's head by 90 degrees, now the patient is looking at the left upper corner of the room. So you see my hand, right upper corner, now left upper corner. Now what you do is you will roll the entire body along with the head by another 90 degrees. Okay, so when you roll the body, what happens now? Now the head is looking at the left lower corner of the room. Okay, so this is the next step. The patient head and the body both are turned. Patient is looking at the left lower corner of the room. And then after this, finally, you bring the patient back to the sitting position. Okay, so this is Eplase maneuver. Now you see the patient sat on one side of the bed. Patient will get up from the other side of the bed. So this is your Eplase maneuver. Remember, Eplase maneuver is the treatment of choice for BPPV. Which type? Posterior canal type. Okay, this one episode of Eplase maneuver, it treats approximately 90% cases for posterior canal BPPV. In remaining 10%, you have done one sitting, you can do the next sitting also. Okay, so even single sitting is so effective for treatment of BPPV. Alright, let's look at this Eplase maneuver once again. In this video, you see you turn the patient towards right side, you make the patient go supine, then you turn by 90 degree to the other side. Now you roll the whole body and the head 90 degree by the other side, and then you bring the patient back, okay, to the sitting position. That is your Eplase maneuver. Right? Remember, this is the treatment of choice for BPPV, especially posterior semicircular canal type. Now, other than the Eplase maneuver, we can also do the Siemens or the laboratory maneuver. Now, what is done in Siemens or the laboratory maneuver? Now, this maneuver, once again, the step 1 is same as Dix-Hallpike maneuver. So, what you do? You make the patient sit on the examination table. You turn the head 45 degrees to the side you are going to test. Okay, your idea is that the side you are going to treat, that side should go down. Okay, that side of the head should go down, that ear should go down, that bad ear. Okay, remember it, like the bad ear has to be down. So you make the patient go supine. Alright, just like you did in Dix-Hallpike, and patient has vertigo. So you confirmed your diagnosis. Okay, you did Dix-Hallpike, you confirmed the diagnosis. Now you can either do Eplase or you can do Siemens. Now what we do in Siemens is that after this, we make a complete arc of 180 degrees. We make the patient go to the other side. Okay, and that will complete the Siemens maneuver. So you see, this Siemens maneuver is relatively easy. But on the other hand, because of the sudden movement, some patients are not comfortable. So we don't prefer to do Siemens maneuver as much as we prefer to do Eplase maneuver. However, it depends upon treating physician to physician. Some physicians, they prefer Siemens maneuver over Eplase, but usually worldwide Eplase is more commonly used. So that is considered as the treatment of choice. Okay, now after any of these maneuver, both these maneuver, Eplase and Siemens, once you have replaced the otogonia back into uterine saccule, for the next 24 hours, you ask the patient to be in the Fowler's position, okay, head up position, right? So the patient has to sleep in this head up position for the next 24 hours, and thereafter the patient can go to the usual activity, right? Okay, now sometimes patient has recurrent attacks of BPPV. So if the patient has recurrent attacks of BPPV, we can advise the patient a set of exercises which are known as branded Daroff exercises. So these branded Daroff exercises, number one, these are to be done at home. Okay, they can be done by the patients themselves, and they are used in case of recurrent BPPV. Okay, in case of recurrent BPPV. Now, how are these exercises done? Patient can do these exercises 3 times a day for 10 days, and usually it takes care of recurrent BPPV. Now, what is done in branded Daroff exercises? Branded Daroff exercises are very simple. You ask the patient to sit on a bed, okay, and then the patient lies down on the side that is affected. Here the patient will spend 30 seconds, okay. After 30 seconds, patient comes back to the sitting position, again spends 30 seconds. Then the patient goes and lies down on the other side and again spends 30 seconds and then comes back to the sitting position. Okay, so this is known as branded Daroff exercises, and they are used to treat recurrent BPPV at home. Right? So this was the BPPV due to the posterior semicircular canal. Rarely we can also have the BPPV due to the lateral semicircular canal. Okay, so when we have it due to the lateral semicircular canal, how do we treat that BPPV? We treat it by a maneuver that's known as Lampert's maneuver. Okay, so now what is done in the Lampert's maneuver? In the Lampert's maneuver, you can see that this patient is lying supine. Now the patient turns to the left. So you're treating the right side, the patient turns the head towards the left side, okay, by 90 degrees, right? Now, after this, patient moves the entire body along with the head, and now the head has again turned 90 degrees. Patient is prone and the head has turned 90 degrees, okay? So now the patient is looking down. The next step, the patient turns once again, and now the head is turned, patient is looking at the right side. Okay, finally, you see the patient moves the body and then gets up in the sitting position. This is known as the Lampert's maneuver. It is done for lateral semicircular canal BPPV. Right? So remember, L for lateral, and L for Lampert's. Okay, another maneuver which is done for lateral semicircular canal BPPV is your log roll or barbecue test. Now what is done in log roll or barbecue test? Log roll or barbecue, again L for log and L for lateral semicircular canal BPPV. Now in this you move the entire patient or the entire body like a log of wood. Okay, now you see in the previous test, the Lampert's test, as you saw over here, you could move head separately from the body, but here in log roll, you will move the entire body along with the head. Okay, so in this step 1, you see the patient lies down with the affected ear down, the bad ear is down, right? So the step 1, the bad ear is down. Now step 2, patient moves the entire body along with the head. Now the patient is looking up, okay, and now you see the patient is in supine position looking up. Step 3, patient rotates completely to the other side. So now the bad ear, the affected ear is up. This is your position 3. The patient is looking on the left side. And finally, the patient gets up in the praying position. Okay, so this is your log roll or the barbecue test, that is barbecue maneuver, that is used for lateral semicircular canal BPPV. Right? Okay, now let's look at a few questions. Number 1, Hallpike maneuver is done for. So you see vestibular function, audiometry, cochlear function, corneal test. So we know it is done for vestibular function to diagnose BPPV. Right? Next question, a patient presented to ENT OPD with complaints of vertigo and nausea in the morning on change in position of the head. You see, so there is vertigo on change in head position. What is your diagnosis? Okay, so vertigo with change in position of head, positional vertigo, we have BPPV, benign paroxysmal positional vertigo. Okay, remaining labyrinthitis, vestibular neuronitis, Meniere's disease, they may have vertigo, but none of that is with change in position of head. We will be studying about these later on. Right? Okay, next. Name the maneuver shown in the image. So question asked in Jan 2019, NEET PG, Lampert, Siemens, Branded, Daroff, Epley. So this maneuver was shown over there. You can see that the patient is having a series of head movement where you are trying to reposit the otoconia back. So that is your Epley's maneuver. Okay, over here you can see the remaining maneuvers names were given. I have explained you each and every movement. The Branded Daroff exercises, okay, so you can see they are non-assisted exercises. Here you can see the patient head is being assisted by a physician. All right, so these are not Branded Daroff exercises. Then you have seen Branded Daroff exercises are totally different. The Siemens and the Lamperts are again two different exercises. Siemens is totally different, done for posterior semicircular canal, but it's entirely different. Lamperts, again it is different, it is done for lateral semicircular canal. So we have discussed all these different maneuvers, and the answer over here is Epley's maneuver. Okay, right. Let's look another question asked recently in the June 2020 exam. A clinical case of vertigo lasting for a few seconds. So you see, patient has vertigo, and number two, patient has this vertigo for a few seconds associated with movement of head posture. Right? Okay, so vertigo for few seconds associated with movement of head posture. Our provisional diagnosis is BPPV. The condition was treated with Epley's maneuver. So condition has already been treated. Okay, so that means that confirms our diagnosis of BPPV. What is the diagnostic test? So what is the diagnostic test for BPPV? We know answer is Dix-Hallpike maneuver. Okay, Branded Daroff we have already studied. Epley's is the treatment. Okay, Heimlich maneuver. What is Heimlich maneuver? Heimlich maneuver is the maneuver used to take the foreign body out of the airway. Okay, now this maneuver is done when the foreign body is in the airway such as the trachea. Okay, remember this maneuver is not to be done when the foreign body is in one of the bronchi or the patient is having incomplete obstruction. Why? Because this maneuver can convert incomplete obstruction to a complete obstruction. This is done only when the patient is having complete obstruction, is undergoing cyanosis, is undergoing complete choking. So this can be a life-saving maneuver in that case. What you do in this maneuver, as shown over here, you make a fist. Okay, so with one hand, with the left hand, you make a fist. You put it on the sternum and you stand behind the patient. With the other hand, you hold this fist and then you give a thrust. Okay, so when you give a thrust inside on the sternum, then it will throw the foreign body out. Okay, just be remember not to break the bones. Okay, so yes, you have to give force, but not as much as to break the bone. All right, so that is your Heimlich maneuver. So now after this, let's discuss the tests of the vestibular system. We have seen the BPPV, we have seen the test of BPPV and the treatment. Let us discuss the remaining test for the vestibular labyrinth. And the first that we have to discuss are the caloric tests. Okay, the first caloric test, there are three types of caloric test. The first is the Fitzgerald-Hallpike test. Now, what do we do in the Fitzgerald-Hallpike test? As you can see over here, in this patient, we are putting something in the ear. So, what are we putting? We do syringing. In Fitzgerald-Hallpike test, we do syringing with 37. Remember, 37 degrees Celsius is the core body temperature. So now we do syringing with plus minus 7 degrees Celsius. So that means we do syringing with 30 degrees Celsius and 44 degrees Celsius water. Okay, 30 you see over here, 30 is a cold stimulus and 44 is a warm stimulus. Right? 30 is a cold stimulus, 44 is a warm stimulus, and the Fitzgerald-Hall-Pike test, the mnemonic is cows. So what do I mean by that? You see, what are you doing? You are doing syringing with hot and cold water. So let's say you are doing syringing with cold water. What will happen? So you do syringing, the water goes in the EAC, comes back. The temperature of EAC goes down. Okay, now because the temperature of EAC goes down, because of that the temperature of middle ear will also go down. Now the middle ear temperature goes down. What is there in middle ear? In the middle ear we have the lateral semicircular canal. Okay, so that means you are giving a cold stimulus to the lateral semicircular canal. So remember, caloric testing, you are stimulating the inner ear. Which part of inner ear? You are stimulating the lateral semicircular canal. And when you stimulate the lateral semicircular canal, what happens? There is nystagmus. What kind of nystagmus? It's a horizontal nystagmus. Okay, now if you give a cold stimulus, you see, if you give a cold stimulus, then nystagmus is towards opposite direction. Okay, the fast component is towards the opposite direction. If you give a warm stimulus, okay, then nystagmus is towards the same side, towards the same ear. So cold, opposite, and warm, same side. Right? So cows, cold opposite, warm same side. So that is the Fitzgerald-Hall-Pike test. Alright, it will give the nystagmus. Now what is the advantage of this test? You see, the advantage is clear. So you want to see whether something is alive, something is functioning, you give a stimulus. If the response comes, you know it is working, it is functioning. If there is no response, that means it is not working. If the response is less than appropriate, that means it is diseased. Okay, right? If the response is delayed, that means again there is a problem. Alright, so this is how we can diagnose the problem of vestibular labyrinth by the Fitzgerald-Hall-Pike test. Now, when we did this test, we found that out of cold and warm, cold is a stronger stimulus. Okay, so instead of doing two tests, giving with cold, giving with warm, now what was decided? To give only the cold stimulus. Alright, so we have the modified Kobrach test, also known as cold caloric test. So what is done in this test? In this test, you do syringing with ice cold water. That means water at 0 degree Celsius. Okay, so you see, now you are giving the maximum possible cold stimulus. At 0 degree, water can be solid, it can be liquid. But below 0, it will always be solid. So you cannot do syringing with ice. You can do syringing only with liquid form of water. Right? So now you do syringing at ice cold water, modified Kobrach test. Okay, so what happens in this? See, if the response has to come, it will come with cold. Cold is a stronger stimulus. If there is no response at 0 degrees Celsius cold water, that means it will not come even with the warm solution. Okay, so this is your modified Kobrach test. Now remember, when I taught you about syringing in the topic of anatomy of external ear, so I told you syringing is the way where we can remove the foreign body from the EAC. Now at that time I told you that when we do syringing for removal of foreign body, this syringing, the water has to be at 37 degrees Celsius, that is core body temperature. Why? See, if you do syringing above or below 37, you will be stimulating the inner ear, patient will have nystagmus and vertigo. Okay, so that will now become caloric testing. It will no longer remain just simple syringing. If you have to remove the foreign body, you have to give the water at 37 degrees Celsius to avoid caloric stimulation to the inner ear. Okay, right. Now I also taught you the contraindications of syringing. So the biggest contraindication to syringing was tympanic membrane perforation. So suppose there is a patient who has tympanic membrane perforation and you want to do caloric testing. So what will you do now? Now you will do Dundas Grant test. So now what is done in Dundas Grant test? Now you cannot put water, so you put cold air. So what is done? This is a copper tube. You see, this is a copper tube and it's a coiled copper tube and you put some spirit on it. So now what will happen? The spirit will evaporate. When the spirit evaporates, this coiled copper tube, it will become cold. And now you can blow in air. So when you blow air, the air goes to this cold copper tube, it will come out as cold air, and this cold air goes in the EAC and the middle ear, and it will stimulate the lateral semicircular canal. Patient will have the caloric test. So this is your Dundas Grant test. Okay, it is done in a perforated tympanic membrane. Right? Okay. Now let's look at this question asked in the AIIMS May 2018. Caloric test was done on the right side with cold water. Okay, so right side we did it with cold water. Eyes moved to the opposite side, of course. Okay, the cold, if you do give a cold stimulus, the eyes will go towards the left side. The fast component is opposite. We know that mnemonic. Which of the following corresponds to the correct interpretation of nystagmus in this test? Okay, fast component to the left side. Yes, whenever we say the nystagmus is going to the opposite side, that means the fast component is going to the other side. Remember, direction of nystagmus is given by the fast component. Okay, so that was the answer. Immediately you can see over here, this is the answer. Slow component to left side is wrong. Fast component to right side, that will be wrong. Okay, slow component to right side is there, but the slow component does not determine the nystagmus. Direction of nystagmus is given by the fast component. Okay, so choice A is the right answer in this question. Okay, now other than the caloric test, we can do some more tests to check for labyrinth. Number one is VAMP. What is VAMP? Vestibular evoked myogenic potential. Okay, so what is this then in this? You see, vestibular evoked. So you give a stimulus, you give a sound stimulus. Now we have not only the vestibulo-ocular reflex, we also have the vestibulospinal reflex. Now the vestibulospinal reflex, this vestibulospinal reflex, you see, whenever there is a change in the head position, it gives a reflex to the spine. All right, and what happens because of that? The body postural muscles are maintained. All right, okay, so that you remain in balance. So now the VAMP utilizes that. Whenever the vestibular system is evoked, there will be changes in the muscle potential, myogenic potential. All right, so you give stimulus in the ear to stimulate the vestibule and you check for changes in the muscle potential. Now this VAMP can be of two types. Number one is cervical VAMP. So what we do in cervical VAMP, you give the sound stimulus in the ear and you check for changes in the sternocleidomastoid muscle, cervical neck, sternocleidomastoid muscle, you can see over here. Okay, so now you see the SCM is below the ear. So how do I remember it? SCM is below the ear. So this evaluates saccule. S for SCM, sternocleidomastoid, S for saccule. Okay, so S for saccule, S for SCM. So it evaluates saccule and inferior vestibular nerve. Below the ear, inferior vestibular nerve. Okay, and then we have the ocular VAMP. We have the ocular VAMP. So now you give a sound stimulus and you check for the change in myogenic potential around the eye, orbicularis oculi. So now you see O is a vowel and U over here is also a vowel. So ocular VAMP, it evaluates utricle, and this is above the level of ear. You can see the electrodes are placed above the level of ear. So it evaluates superior vestibular nerve. So you should remember, cervical web evaluates the saccule, SCM, saccule and inferior vestibular nerve. Ocular web evaluates your utricle and superior vestibular nerve. Okay. Now, the another test that we have these days is galvanic vestibular stimulation. Now, this test, GVS, is mainly used in the research. It is not yet used for clinical diagnosis. But what is done in this? Small voltage current is given to stimulate and check the functioning of vestibular nerve. Okay, so it is known as galvanic vestibular stimulation. Galvanic means current, so you are stimulating the vestibular nerve by giving small voltage current. Okay, so that is your GVS or galvanic vestibular stimulation. Let us now discuss the auditory labyrinth or the cochlea. Okay, so we have already discussed the vestibular labyrinth, the part which is concerned with balance. Now this is the part that is concerned with the hearing, right? So let's look at this diagram. We have seen it earlier. We know that the anterior part is the cochlea, and this cochlea is a bony structure which is a spiral structure having 2.75 turns. Okay, so this bony structure has spiral turns. How many? 2.75 turns around a central bony axis which is known as modulus, right? Okay, now you see, let's do one thing. Let's take a cross section over here, right? So this is the cross section of the cochlea. Now what do we see? We know the cochlea, the bony labyrinth. Inside that there is a membranous labyrinth, and this membranous labyrinth, it has two membranes. You see, it has a Reisner's membrane and a basilar membrane. Now with the help of these two membranes, it divides the cochlea into three parts. Which are those three parts? We can see over here the scala vestibuli, the scala media and the scala tympani. Now we know the scala vestibuli and the scala tympani, they are actually the perilymphatic space. So these are filled with perilymph. Alright, and the scala media is the endolymphatic space. So this is filled with endolymph. Right? Okay, now this endolymph, it is secreted by a special membrane that is known as stria vascularis. Right? Okay, so remember the endolymph, it is secreted in the cochlea by stria vascularis. Now other than this, you can see we have a very special organ on the basilar membrane sitting inside the scala media, that is your organ of Corti. Now organ of Corti, as I have told you earlier also, this is the sensory organ of the cochlea. So this is the most important part of the cochlea, the sensory organ of cochlea. From here, you know, the sound stimulus is converted into an electric impulse and it is given to the eighth nerve. So you can see this eighth nerve fiber coming out of the organ of Corti. Okay, now before we go ahead and discuss the organ of Corti, let's first talk about the endolymph and the stria vascularis. Alright, so let's talk about stria vascularis. So we can see this diagram of the scala media. We have the Reisner's membrane and the basilar membrane, and now we can see that this is the stria vascularis. Right, in this stria vascularis you can see some special cells. Alright, so these special cells are known as marginal cells. What is special about them? These marginal cells, they have a sodium potassium ATPase pump. Okay, now with the help of this pump, they secrete a lot of potassium in the endolymph. Alright, so remember, endolymph is high in potassium and low in sodium. Okay, so sodium is low whereas potassium is very high. Alright, because of that there is a positive charge inside the scala media, whereas the scala vestibuli and the scala tympani, they both have perilymph. Now this perilymph, it is high in sodium and is low in potassium. Alright, okay, now how these marginal cells, they secrete this endolymph. So let's look at the endolymph secretion. So we are looking over here at these marginal cells, and these marginal cells are responsible for endolymph secretion. So somebody asks you, endolymph is secreted by, your answer is marginal cells or the stria vascularis in the cochlea. But do remember that the endolymph is also secreted by dark cells in macula. So macula is in the vestibular labyrinth, all right? So it is also secreted in the vestibular labyrinth by the dark cells in the macula. All right, now we are going to see how the endolymph is secreted by the stria vascularis in the cochlea. So in the stria vascularis, we have marginal cells. So you see marginal cells, they're attached to each other with the help of these tight junctions. And then they separate the scala media from the intrastrial compartment fluid. All right, in the intrastrial compartment fluid, we have sodium and potassium ions. Okay, so now how the endolymph is secreted, we can remember it. Very interesting story. So let's say the sodium over here is the boy and the potassium over here is the girl, okay, his girlfriend. So one day the sodium asks his girlfriend potassium, let's go on a date. Okay, so the sodium takes potassium to a date. Now where will he take her to a date? So he says, let's go to a dance club. All right, so marginal cell is our dance club. So he says, let's go to a club, we'll go and have a good night over there. But the potassium says that I don't want to go to a dance club because there are a lot of boys over there. So sodium tells her that I know a club which is full of girls. So let's go to that club. All right, so sodium and potassium, they go to this club. So now when they reach outside the club, they meet chloride. Now chloride is the agent of the club. He says that if you will come with me, I can get you a free couple entry. So this chloride ion takes sodium and potassium, and all the three of them, they enter into the club, into the marginal cell, free of cost. All right. So free of cost, sodium, potassium and chloride, they have entered inside the marginal cell. Now after entry, what has happened? Chloride job is over. Chloride job is to bring the couples into the club, and then he will go out. He has a separate door to go out. Okay, so you see chloride over here, it comes back out to where it was. So it will stand outside the door and it will search for more couples. So that is the job of chloride. So chloride is out now. Okay, now what will happen inside the club? Now inside the club, you see what will happen? The boy goes and he starts drinking. Now this club has placed some bouncers. Okay, the bouncer over here is our sodium potassium ATPase pump. So this is the bouncer, the sodium potassium ATPase pump. Now what is the job of this bouncer? As soon as the boy gets drunk, so boy was sodium, as soon as the boy gets drunk, so what will the bouncer do? He will throw the boy out of the club. Okay, so this sodium potassium ATPase pump, it will keep on throwing out 3 boys. So 3 sodium will go out, and in return he will allow 2 potassiums to go in. So 2 girls are allowed to go in for every 3 boys thrown out. So that is why the club is full of girls. All right. So you see what has happened. A lot of potassium has accumulated inside the marginal cells. So as you can see over here, this sodium potassium ATPase pump. Now this is placed at a very clever position over here in the marginal cells. It is throwing out all the sodiums out and it is collecting all the potassium inside the marginal cells. So marginal cells are very, very high in potassium, and then this potassium is secreted into the scala media by a special potassium channel. Okay, so this potassium channel secretes all the potassium into the scala media. So therefore the scala media is extremely high in potassium content. Okay, now because of this arrangement inside the marginal cells, you see the electrical potential in the marginal cells reaches up to plus 90 to plus 95 millivolt, and inside the scala media where we have the endolymph, this electrical potential is plus 80 to 85 millivolt. Right, now this plus 80 to 85 millivolt electrical potential inside the scala media, this is known as endocochlear potential. Okay, so this potential over here, this is known as endocochlear potential. Right, so now what is a endocochlear potential? You see, endocochlear potential, as we just saw, this is a normal physiological potential in the inner ear. Okay, it's a normal physiological potential. And how is it produced? It is produced due to sodium potassium ATPase pump in stria vascularis. Okay, sodium potassium ATPase pump in stria vascularis. Right? What is the potential? It is plus 80 to plus 85 millivolt. Remember, this potential is not dependent upon sound. It is a physiological potential. There is no need for sound to produce this potential. Okay, so it is not dependent upon sound. Right? Okay, and lastly, this is a DC potential. So what do we mean by DC potential? You see, a DC current, direct current. Now what happens in that? One side is always positive, the other side is always negative. Right? Similarly over here in the endocochlear potential, the scala media, it becomes positive because of a lot of potassium ion. Okay, and the scala vestibuli and scala tympani becomes negative. So it remains like this. Alright, there is no change in the potential. So that is why this is a DC potential. One pole is always positive, one pole is always negative. Right? Okay, so now let's come to this question. Endolymph is secreted by. So we know the answer. Answer is C choice, stria vascularis. Alright, so now we have seen how the endolymph is secreted. But how is the endolymph absorbed? So you see, to understand that, we come back to this diagram. We have already seen this diagram. This is the diagram of the membranous labyrinth. We can see over here the cochlea, the membranous labyrinth of cochlea. We can see the saccule, we can see the utricle. Now you see between the cochlea and the saccule, there is a duct that's known as ductus reunions. So the endolymph of the cochlea comes to the saccule, and from there it goes into a endolymphatic duct. Now this endolymphatic duct, it takes the endolymph to the endolymphatic sac where it is absorbed. Okay, now the question is asked, where is this endolymphatic sac situated? To understand the location of this endolymphatic sac, let's go and look at this diagram. So this is the diagram of the mastoid cavity that we discussed earlier also in the previous session. Now let's look at this bony labyrinth. So you see, we have the bony labyrinth. In the bony labyrinth over here, we have the superior semicircular canal. This is the posterior semicircular canal. And most importantly, this is the lateral semicircular canal. Right? Okay. Now, you also know that the posterior wall of the mastoid is known as sinus plate because just behind that, we have the sigmoid sinus. Alright. Now, suppose I draw a line on the axis of the lateral semicircular canal. So you see, I draw this line. Now we know lateral semicircular canal is also known as horizontal semicircular canal, but it is actually not horizontal. It is at an angle of 30 degrees to the horizontal or the transverse line. Right? So if I draw this line along the axis of the lateral semicircular canal, so now you see what has happened. This line has bisected the posterior semicircular canal. You see, the posterior semicircular canal has been cut into two halves by this line. Okay, this line is known as Donaldson's line. You see, so what is Donaldson's line? Line along the axis of lateral semicircular canal bisecting posterior semicircular canal. And just where this line meets the sigmoid sinus, so just below that point over here that I am now drawing, we have our endolymphatic sac. Okay, so this place we have the endolymphatic sac. Alright, so where is the endolymphatic sac? It's situated behind the sinus plate. Okay, that means behind the posterior wall of mastoid, just below the Donaldson's line. So what is Donaldson's line? Line along the axis of lateral semicircular canal, bisecting the posterior semicircular canal, and where it meets the sigmoid sinus, Just below that we have the endolymphatic sac. All right. Now, before we go ahead, let us look at this position of the lateral semicircular canal. So this is in the erect or the anatomical position. So as I was telling you that the lateral semicircular canal is at an angle of 30 degrees to the horizontal or the transverse line. So now there are a lot of MCQs which can be made from this position. Now suppose I say, how can we make the lateral semicircular canal vertical? So you have to make it vertical. In the erect position, what will you do? You bend backwards. You bend your head backwards by 60 degrees. Okay, right? So now the lateral will come to 90 degrees. Right? Okay. Now, if you have to make it horizontal, so what will you do? You bend forward by 30 degrees. Okay. So that ways you can make the lateral semicircular canal horizontal or vertical. Now, let's say the patient is in supine position. Okay. So you see, this is the erect position. This lateral semicircular canal is there in the erect position. Okay. That is the anatomical position. Now, suppose I have to make a patient go supine. So what do? From the erect, I turn the patient by 90 degrees. So when I am turning the patient by 90 degrees, so that means this lateral semicircular canal, it also goes back by 90 degrees. So now this is the lateral semicircular canal in supine position. This is the position of the lateral canal. So now you want to make this lateral semicircular canal horizontal in supine position. So what can you do? You can bend the head backwards by 60 degrees. Okay. So now the patient's lateral semicircular canal will come back into horizontal position. So patient is in supine position. Okay. And now the lateral canal is brought to horizontal plane by bending the head backwards by 60 degrees. And somebody asks you, how can you make it vertical in supine position? Simple. You bend the head forwards by 30 degrees, and now the lateral semicircular canal will become vertical. Okay, it will come in the vertical plane. So you see, these questions are very easy. I just wanted you to highlight these questions to you so that you are not confused in the exam. All right, a simple 30-degree angle, you can create these 3-4 questions with that angle also. All right, let's come back over here on the discussion of the inner ear of the cochlea. And now what we do is we unspiral the cochlea. So we know it has 2.75 turns. Now we have unspiraled the cochlea. So what can we see over here? We can see the middle ear. From the middle ear to the inner ear, there are 2 windows, oval window and round window. Okay, now let's look inside the cochlea. You can see that there are 3 parts of this cochlea: scala vestibuli, scala media, scala tympani, divided by 2 membranes, resinous membrane and basilar membrane. Right? Now you see the scala vestibuli and the scala tympani, they both consist of a fluid. Which fluid? Perilymph. Alright, and the scala media consists of a fluid that is known as endolymph. Now if you notice that the scala vestibuli and the scala tympani, both of them are communicating with each other at the apex, and there is an opening at the apex which we call as helicotrama. So helicotrama is a place at the apex of the cochlea where the scala vestibuli and scala tympani, both of them, they meet with each other. Okay, both of them communicate with each other, so that is why both of them have the same fluid, that is the perilymph. Okay, now let's draw a diagram. So this is a diagram that I've drawn for you guys. So you can replicate if you are in a undergraduate third prof, you can replicate this in your exam also. So you see we have the scala vestibuli and the scala tympani, both the scala vestibuli and the scala tympani, they both have the same fluid over here, which I am now marking, that is your perilymph. Right? Okay, so you can see over here an unspiraled version of the cochlea. Right, the scala vestibuli, the scala media and scala tympani, and scala vestibuli and scala tympani, you can see over here, they both communicate with each other at the apex, that's known as helicotrama. Okay, the scala media on the other hand, you can see is filled with endolymph. So this I am now shading over here. So that is your scala media, also known as cochlear duct. So remember, the scala media is also known as cochlear duct. Okay, so sometimes this question is asked. Don't forget the scala media, another name, cochlear duct. Okay, now if you notice over here that the scala tympani, you see the scala tympani, it is communicating with the subarachnoid space. Okay, it is communicating with the subarachnoid space, and in the subarachnoid space there is what? There is CSF. Now this communication is known as cochlear aqueduct, right? So this cochlear aqueduct, it brings the CSF from the subarachnoid space into the scala tympani. Okay, so in the scala tympani, now the CSF is known as perilymph. So what is perilymph? Perilymph is CSF, or you can say it is an ultrafiltrate of CSF, because in this cochlear aqueduct, the CSF filters and comes into the inner ear. So remember, the inner ear perilymph composition is same as CSF. Also, suppose a question is asked during meningitis. So we know during meningitis, what happens? The infection is in the brain. Okay, the bacteria may lie in the CSF, and now this infection can come to the ear also through cochlear aqueduct. So during meningitis, most common route of spread of infection from brain to inner ear, answer is cochlear aqueduct. So this is the most common route of spread of infection from brain to inner ear during meningitis. Right? Okay, so that is your inner ear, the cochlea that we have seen the unspiraled version. Okay, now let's look at this diagram. Let's revise what we have just all studied. All right, so what we can see over here, you can see over here the inner ear, you can see the membranous inner ear, and outer around that there is a bony covering, that is the bony labyrinth, the bony inner ear. Okay, so you can see that this is the cochlear aqueduct, that is the scala media, it has the endolymph. Right, now this is communicating through ductus reunions to saccule, and the saccule is communicating to the utricle and the semicircular canals. Now from here arises the endolymphatic duct. This endolymphatic duct takes the endolymph to endolymphatic sac, as we discussed. Where is the sac? It is behind the mastoid. It is between the layers of the dura, intradural. So this question is also asked. You see that this endolymphatic sac is placed between the layers of the dura. So it is intradural in nature. Okay, now you can see that there is another duct going from the inner ear to the brain. That duct is known as cochlear aqueduct. So you can see that this cochlear aqueduct is starting over here, that is in the scala tympani, and it communicates with the subarachnoid space where we have CSF. So this CSF, it comes through the cochlear aqueduct into the scala tympani. All right, and there it is known as perilymph. Right, now we have seen the anatomy of the cochlea. Let's go and discuss the sensory organ of the cochlea, the most important part of the cochlea, that is your organ of Corti. Okay, so we know that this organ of Corti, it rests on the basilar membrane. So what are the parts of this organ of Corti? You can see that this organ of Corti, I have placed different colors to different cells. So we can see over here, there are outer hair cells, there is inner hair cells. Now other than these two important cells, we have some other supporting cells such as cells of Hensen, cells of Claudius, the Boucher cells, the Dieter cells, etc. Okay, so we'll study this organ of Corti. Let's have a magnified view of the organ of Corti. So once again, you can see over here the most important covering these cells is the tectorial membrane. All right, so this over here is the tectorial membrane in the organ of Corti. Other cells you can see over here, we have the outer hair cells, the inner hair cells, the cells of Hensen, cells of Claudius, Boucher cells, Dieter cells, and we have some other structures such as the tunnel of Corti, the most important, from these hair cells, you can see the nerve fibers coming out. Okay, and these are the nerve fibers of which nerve? The cochlear nerve, right? And this organ of Corti converts the sound stimulus into an electrical impulse, gives it to the cochlear nerve, which takes it to the brain. All right. The most important for us to study in this organ of Corti is the outer hair cells and the inner hair cells. We should know the difference between the outer hair cells and the inner hair cells. All right. So let's study the difference between the outer hair cells and the inner hair cells. It's very easy to remember the difference. How can we remember the difference? Outer starts with O and we can say more. Outer, more. The mnemonic is more. Okay, everything is more in outer hair cells. How? Outer hair cells are more in number. They are 12 to 14,000 in number, whereas inner hair cells are only 3,500 in number. Then outer hair cells are more in rows, 3 to 5 rows. Inner hair cells are arranged in single row. Look in this diagram, you can see 3 hair cells. These are the 3 outer hair cells, and you can see only one single row of inner hair cells. So inner hair cells, single row, outer hair cells, more rows, 3 to 5 rows. Then outer hair cells, they take more time to develop. They have late development, so more time. Inner hair cells, they develop early. Okay, so something that develops early is stronger, something that develops late is more sensitive. All right, just remember that. Now, the outer hair cells, they amplify the sound. So whatever sound is received by the organ of Corti, the job of the outer hair cells is to make it more, to amplify. Okay, and then give it to the inner hair cells. The inner hair cells, they do mechanico-electrical transduction. So that means they convert the mechanical energy into electrical energy, electrical impulse, and give it to the 8th nerve fibers. All right, now as I said, the outer hair cells, they are more sensitive. So they are more sensitive to ototoxic drugs, and they are also more sensitive to acoustic trauma, noise-induced hearing loss, whereas inner hair cells are less sensitive. All right. Now, finally, the outer hair cells, they also produce OAE. OAE stands for autoacoustic emissions. Okay. Now, what are these autoacoustic emissions, OAE? So we'll talk about them. Now, before we talk about OAE, we have to talk about the ototoxicity. Okay. So we talked about the ototoxic drugs. So we'll talk about ototoxicity. But first of all, let's go and do this question. A steel worker presented with noise-induced hearing loss. So noise-induced hearing loss. Now, which part of inner ear is most likely affected? So which is the most sensitive part of inner ear to the noise-induced hearing loss, acoustic trauma? We know it is the outer hair cells. Okay, remember on the outer hair cells, there are hairs which are known as stereocilia. So these stereocilia of the outer hair cells, these are the first to be affected by acoustic trauma, noise-induced hearing loss. Okay, so remember, these are the first to be affected in noise-induced hearing loss. All right, let's come to ototoxicity now. So, what are the drugs which cause this ototoxicity? So, we can have number one, the aminoglycosides. So, now remember about aminoglycosides, they cause irreversible ototoxicity. Okay, so this ototoxicity is irreversible. Now, aminoglycosides, we can have drugs such as gentamicin, streptomycin. These are specific vestibulotoxic drugs. Okay, so they cause more harm to the vestibular labyrinth compared to auditory labyrinth. Whereas drugs such as kanamycin, amikacin, neomycin, tobramycin, these are specific cochleotoxic drugs. So that means they cause more harm to the hearing than they cause to the vestibular labyrinth. All right, these were the aminoglycosides causing irreversible ototoxicity. Then we have the platinum-based chemotherapy drug. These cause reversible ototoxicity. Now remember, the reversibility is only in the initial phase. Later on, they also become irreversible. Okay, so example of platinum-based chemotherapy drugs are you know, cisplatin, carboplatin. Okay. Next we have loop diuretics. Now, loop diuretics, they cause dose-dependent ototoxicity. Dose-dependent means at 20 milligram, for example, the furosemide will not be ototoxic. At 200 milligram, it will be severely ototoxic. Okay, so most drugs, they generally have dose-dependent toxicities. So, loop diuretics, example, furosemide, ethacrenic acid, bumetanide, they all have dose-dependent ototoxicity. Next, we have macrolides such as erythromycin. Okay, we have anti-malarial drug, quinine, chloroquine, hydrochloroquine. Right? We have NSAIDs, ibuprofen, naproxen, indomethacin. Right? We have chemicals such as alcohol, tobacco, marijuana, carbon monoxide poisoning. So all these are ototoxic. Finally, some other drugs may also show ototoxicity such as ampicillin, propranolol, propylthiouracil, dexferoxamine. So these may all show ototoxicity. Okay, right? Now let us look over here between aminoglycoside and cisplatin. So this question has been asked. You see what happens when an aminoglycoside enters into the outer hair cells. So this aminoglycoside, when it enters into the outer hair cell, it first combines with iron. So you can see over here, there is a complex form that is known as aminoglycoside iron complex. And this aminoglycoside iron complex immediately stimulates the ROS pathway. So we know from the pathology, the ROS pathway of apoptosis, and this pathway will lead to apoptosis and the cell will die. So therefore, aminoglycoside causes irreversible ototoxicity. Okay, right? This question has been asked that aminoglycoside after entering into the outer hair cell combines with, which is the first compound it combines with. So answer is iron. Now, the cisplatin on the other hand, you see, the cisplatin, when it goes inside, it combines with MHC protein. Okay, now this MHC CP complex, it will stimulate and lead to collection of NOx3, nitric oxide. Okay, and this nitric oxide, once it has accumulated in a good quantity, it will then further stimulate the ROS pathway of apoptosis. Right? So you see that in the cisplatin, first there is collection of nitric oxide and then only there is stimulation of ROS pathway. So in the initial phase, this may be reversible, but in the later phase, once the ROS pathway is stimulated, it also becomes irreversible ototoxicity. Right? Okay, so that was the ototoxicity difference between aminoglycoside and cisplatin. Now let's come to this question, which of the following is a cochleotoxic drug? So question was asked in the FMG December 2017 exam. So cochleotoxic drug. You see, streptomycin, gentamicin, these both are what? They are specific vestibulotoxic drug, whereas we studied about kanamycin. Kanamycin is a specific cochleotoxic drug. Okay, so remember kanamycin, amikacin especially, these are cochleotoxic drugs. Now, before we finish this topic, we have to study about OAE. OAE stands for autoacoustic emissions. What are these autoacoustic emissions? Now, autoacoustic emissions, these are low intensity sounds. Okay, low intensity sounds produced by outer hair cells. You see, what do we expect? We give a sound stimulus to the outer hair cells. What do we expect? The outer cells, they start working. They amplify this sound. They make it more. They give it to the inner hair cells. The inner hair cells will give it to the ethna. That's what we expect. But when the outer hair cells, they start working, they themselves produce a sound. Okay, this sound is known as OAE. Now, you are not able to hear this sound. Okay, but if you put a very, very sensitive microphone in the EAC, it can pick up this sound. It can detect this OAE. Right? Okay, so these very, very low intensity sounds, if present, what is the benefit? The benefit is we know that the outer hair cells are working. They are functional. Remember, outer hair cells, they are very sensitive to ototoxicity. They are very sensitive to the acoustic trauma. Okay, so if we can detect autoacoustic emissions, we know that the outer hair cells are not damaged. They are still working. Right? Okay, so that is the utility of these autoacoustic emissions or the OAE. Now, this OAE, they can be of two types, spontaneous OAE and evoked OAE. So what do we mean by spontaneous OAE? Spontaneous means without any stimulus. So that means you put a microphone in the ear and you start detecting some OAEs. Right? Now, the outer hair cells at times may be silent, at times they may be producing sound. Okay, so even if they are silent, they are not diseased. Without stimulus, that means spontaneous OAE may be present, may be absent. It does not make a difference. Therefore, spontaneous OAE has no clinical significance. Okay, the clinical significance is of evoked OAE. That means if you give a stimulus, a sound stimulus, then the outer hair cells have to work. If they are not working despite a sound stimulus, that means there is a problem with them. Okay, so clinically significant for us are the evoked OAE, right? And these evoked OAE can be of further two types. Transient evoked OAE, that is known as TEOE, and distortion product OAE, also known as DPOE. So transient evoked OAE, if you give only one frequency of sound, okay, if you give only one frequency of sound, that is known as transient evoked OAE. Now the transient evoked OAE with one frequency, it will just tell you whether the outer hair cells are working or not. Okay, it is a very sensitive test. It will just tell whether inside the cochlea the outer hair cells are working or not. Okay, now distortion product OAE is a specific test. Now what you do in this, you give two different frequency of sound. Okay, now you give two different frequency of sound, and so that you can find out at which place these OAE, these outer hair cells are working. Okay, so you can even find the frequency at which the outer hair cells are working by giving stimulus of two different frequencies. So that is known as DPOE. So DPE is more specific for a particular place in the cochlea, right? Okay, now suppose we have to use OAE. We want to use OAE as a screening test. Can we use? Yes, we can use. We can use OAE as a screening test to detect hearing, especially hearing loss in neonates. Okay, so this OAE is used as a screening test for neonatal deafness. This is in the UPPCD, Universal Program for Prevention and Control of Deafness. Okay, so that is the Indian National Program for Control of Deafness, and in that every newborn has to be screened within the 72 hours with OAE for any hearing loss. Okay, so OAE is used as a screening test for neonatal deafness. And which type of OAE we will use? The more sensitive one, that is the TEOAE. Any other use of OAE other than the neonatal deafness? Yes, they can also be used to detect the ototoxicity. These are the most sensitive tests to detect ototoxicity. They are also the most sensitive tests to detect noise-induced hearing loss. Why? Because the outer hair cells are the first to be affected by ototoxicity and by noise-induced hearing loss. And these outer hair cells themselves, they produce OAE. So any problem in OAE, that means there's a problem in the outer hair cells. So this is the most sensitive test to detect ototoxicity, most sensitive test to detect noise-induced hearing loss. You know, it can detect ototoxicity and noise-induced hearing loss even before they have caused some visible change in the hearing of the patient. So some visible change in the audiometry of the patient. Okay, so this OAE is nowadays also used while giving autotoxic drugs. So before giving the autotoxic drugs, you do OAE, and after giving or while the dose is given, immediately after the first dose, second dose, you start doing the OAE. So if this is starting to cause a problem in the outer hair cells, you can change your drug. You can stop the drug and you can change the drug. You can prevent the autotoxicity by these drugs. Okay, right. So this is the benefit of the OAE that we have nowadays.